Hello class, this is Mr. Wise, and today we're going to be going over our introduction for this week's unit of instruction, Respiratory Disorders of Childhood. And we're going to be covering three in particular. It would be impossible to cover everything, but these three give us a good idea of the variability of respiratory disorders that these children face. The first is asthma, which, as I'm sure many of you have heard of, is a chronic inflammatory disease of the airway. This causes swelling and inflammation in the airways, limiting airflow. Things you'll hear with this are wheezing and the asthma cough, common to these children. Bronchopulmonary dysplasia, or BPD, is something that occurs in preterm newborns or very low weight newborns. And because of their need for oxygen or ventilator support, since their lungs are underdeveloped, their alveoli become damaged and stretched out, and they develop further breathing issues. Finally, cystic fibrosis, or CF, is a hereditary disorder. This is something that interferes with an important protein in the lungs. And because this protein is not functioning properly, chloride cannot make its way to the surface, and the result is thick, sticky mucus that occludes airways and traps microorganisms, resulting in recurring lung infections, among other issues associated with this disorder, but we'll get to that later. Here we have some important key points and little factoids about each of these disorders. Here you can see asthma is by far the most prevalent among the three, with 1 in 12 children approximately having asthma, followed by BPD. And these are children that are developing this, newborns I should say, developing this as a result of their treatment. And finally followed by CF. As of last I checked, the total number is a little over 30,000 of current cases, and this is a fairly rare disease when compared to the others that we'll be discussing. And here we have some more information about these diseases. For example, 5% of children with asthma are hospitalized each year, which can be scary. These children generally represent a small portion of that population, but when they are brought into emergency with these breathing issues, it's generally status asthmaticus, which requires aggressive treatment with steroids. Many of these children are having asthma attacks, as you can see. About half of asthma patients report having regular asthma attacks, and half missing school because of it. BPD, as I stated earlier, is actually something that children are not born with because they're premature and their lungs are not developed. This is something that happens as a result of treatment and then needs to be contended with after the fact. CF, because it's hereditary, has that genetic component. It's pretty well understood. Parents who are carriers, whether it's one or both, dictate how much of a chance these children have of developing CF, which then requires a multi-step process of newborn screening, genetic testing, and then finally the sweat test to detect chloride, which will tell providers whether or not these children are positive for CF. Here we can see the signs and symptoms classic to these disorders. As I mentioned earlier, asthma, for example, you hear that wheezing and coughing that is common with these children. There's some overlap in the disorders you might see as far as your signs and symptoms go. However, each is unique in their own way. These are things that you see varied in terms of their severity and their presentation patient to patient. It really depends on how well their condition is managed. CF in particular is something that has a lot of variability patient to patient depending on its severity and how strict patients are in following their treatment regimen. For each of these, though, it's important that these symptoms be managed appropriately. They can be just as disruptive one to the other depending on their level of management, and patients who are well controlled still have to contend with that regimen in their day-to-day life for the nurses working in acute care, we see them when they're not doing well. For those of us working in the community, we see them when they are managed or managing not to have an exacerbation, but their current level of stability is really dependent on what kind of complications they're dealing with and how well it's being managed in the community. And that's where our part as nurses comes into play. We really have a responsibility to educate people on their treatment regimens and to help support them so that they can stay in the community. Treatments for each of these diseases, again, overlap a little bit, but they do vary. Asthma is probably the most straightforward. The treatment regimen generally consists of use of a control med and a rescue med. And as you will see, children who are having to use their rescue med more frequently are likely not following their treatment regimen, or the prescribed treatment regimen is no longer effective. So that's an important point to consider, especially for nurses in the community. For example, if you're working in a school and your child's using their asthma pump 3 times a week, their albuterol, chances are they're not using their maintenance meds correctly or at all. BPD, this is something that's generally addressed in the acute care environment because these are children who are developing it after they're born. So a lot of the management takes place right then and there. But these children can continue struggling into their school age years. For example, I've worked with children who are just starting to come off oxygen and just starting to tolerate regular ambulation and activity as late as first grade, depending on their level of developmental disability. So that can carry on for some time before they really move past it. And finally, CF is a lifelong thing. There is no cure for that. Again, severity varies from person to person, but the treatment regimen is pretty intensive and involves not just medications, but lifestyle modifications and treatments like airway percussion to remove secretions. So this can be quite time consuming. And depending on how severe it is, this can include additional treatments or interventions, such as having to start insulin because of pancreatic failure or using supplemental O2, or even going so far as needing lung transplants, which would be unfortunate for these children because the goal of our care is to keep them healthy enough to function in the community. And what we're going to be covering in this course, we'll cover both acute and community care. It's important to understand the acute area because this is where we're going to see a lot of children for those of us that work in hospitals, and knowing how to manage these issues while they're having complications or even in crisis is vital. But just as important, we need to know how to help them maintain while they're in the community because these children have lives to live with their families, and it's important for us to understand that and to provide support. So I'm looking forward to teaching everyone about this topic, and I think you guys are going to learn a lot of interesting things.